Dr. Asrik Mukhopadhyay for his presentation on transnasal fixation with novel 10 proline suture in multi-stage correction of blepharophimosis.
Hello. Good morning, everyone. Today I'll be talking about transnasal fixation with novel 10 proline suture in multi-stage correction of blepharophimosis. I am Dr. Asrik Mukhopadhyay, and this work was done under the guidance of Professor Dr. Shalil Kumar Mondal from AIOC Kolkata. And we have no financial interest. Now, as we all know, blepharophimosis syndrome complex is a rare disease with features of epicanthus inversus, telecanthus, lateral ectropion, narrowed horizontal palpebral fissure, and ptosis. It is mostly bilateral and presents as autosomal disease, and various surgical techniques have been described for correction of this disorder, and here we are going to present one such technique. We aim to perform a two-stage correction. In the first stage, telecanthus and epicanthus was corrected by Mustard's double Z plasty and transnasal wire fixation using the novel 10 proline suture. And in the second stage, after 3 months, lateral canthoplasty was done for widening of the horizontal palpebral aperture, and Fox pentagon tarsofrontal sling with silicone tube was done for ptosis correction. This was a prospective interventional case series of 25 patients over a period of 4 years, and all the patients had blepharophimosis syndrome with prominent epicanthus and telecanthus. They underwent a full ophthalmological evaluation before surgery, and informed written consent was taken from the caregivers. Patients included were between ages 5 to 45 years with presence of all the components of blepharophimosis syndrome and moderate to severe ptosis. And the patients excluded were those with vertical squint, poor Bell's phenomenon, Marcus Gunn jaw winking phenomenon, mild ptosis, and previous ptosis surgery, as these may complicate our findings. Preoperatively, we measured the inner canthal distance and horizontal palpebral fissure, and this was followed up for 1 year after surgery, and comparison of the preoperative and postoperative measurements was done, and we made out the intercanthal distance by horizontal palpebral fissure length ratio. This is a table depicting all the individual measurements of each of the 25 patients, and to summarize, of the 25, 16 were females and 9 were males with ages between 8 to 16 years, and all of them had bilateral involvement, thus right eye of each patient was considered. Now we can find that preoperative inner canthal distance was 40.42 millimeter, and it reduced to 32.67 millimeter post-surgery after correction of telecanthus. Similarly, preoperative horizontal palpebral fissure length also improved from 21.89 millimeter to postoperative 28.18 millimeter. The ratio, inner canthal distance to palpebral fissure length ratio, reduced from 1.84 to 1.16, whereas the MRD1 value improved from 1.12 to 3.44 millimeter. This is a video of the surgical procedure. First, skin incision is being shown for the Mustard's double Z plasty for correction of the epicanthus. Following creation of the flaps, a transnasal tunnel is created with a 3.5 gauge manual orthopedic drill, and 10 proline suture is being passed through there for the deep component of the medial canthal tendon for close approximation and correction of the telecanthus. And after proline suture tightening, the skin is closed with 3-0 silk, and this ends the first stage after lateral ectropion correction by flap transfer from upper lid to lower lid. Now after 3 months, we are performing the second stage where lateral canthoplasty is being done for further widening of the horizontal palpebral fissure length, and ptosis is being corrected by Fox pentagon tarsofrontal sling using silicone rod. And after end, we can see there is adequate, acceptable cosmetic and functional outcome. In this study, we were fortunate that all of the patients had good vision with no amblyopia, as they maintained their vision by compensatory chin elevation. And we found out that epicanthus inversus and telecanthus should be corrected in a separate stage before ptosis correction, as the tension created by the respective surgeries are in different vectors and oppose each other. Thus, we corrected the telecanthus and epicanthus in the first stage and the ptosis in the second stage. The newer novel material that we have used is the non-absorbable 10 proline suture, which is used for transnasal wire fixation and causes close approximation of the two medial palpebral ligaments via the intranasal bone tunnel. This suture is thick and non-absorbable, thus guaranteeing long-term tensile strength. It is also easy to introduce in surgical procedure, as it is cost-effective and provides effective traction of the ligaments and better reduction of the intercanthal distance. Other materials like stainless steel wire or titanium are difficult to procure and require special instrumentation. Now, as I have already mentioned, various techniques have already been described in different studies like levator resection, maximal levator resection, Z epicanthoplasty, YV procedure,